Colby Simmons. I am from Springfield, Missouri. I'm a Cardinals fan. I'm sure you are. Okay, good. And I did medical school in Kansas City. I came here for my residency. I stayed on to do a year of neuroanesthesia fellowship. I had done clinical neurophysiology before medical school, so it was kind of right up my alley to want to stay and work with the neuro team, because we monitor, or we are in charge of neuromonitoring here, which is something that's unique and something you all will get to take part in as during your neuro months. And then I'm also the director of our global anesthesia program, which I started as a CA3 resident. I won a scholarship to go travel to Uganda, but before that I had been interested in global health anyway. But went to Uganda for a month and then came back and proposed this program to our department chair, and she was very on board. And so this last year we took our first resident to Uganda, and this year we'll take our second. And we're applying for a grant right now to teach point-of-care ultrasound in Uganda via teleconferencing system. So anyway, so that's something hopefully if you have any interest in as a CA2, you'll apply to the program and you get to take a all expenses paid trip for 1 month to Uganda, which includes a month of no call requirements, getting to hang out and learn about a very distinct, different culture and system of anesthesia where most days they don't have electricity or water, and you get to try to navigate that system. So today we're going to talk about OR emergencies. This morning we're not really going to get into any specific emergencies. The point of this lecture is not to make you an expert in managing all the different types of emergencies, to give you an idea of how you can become the captain of the ship when things start going south. There are lots and lots of different kinds of emergencies that you will come across, but most of them all can be boiled down to how do you manage it, how are you managing the room, and how do you allocate resources, time, and efforts to give the patient the best opportunity for success. So we will talk about that, and then this afternoon we will do some case-based learning, problem-based learning, and have you kind of just role play different OR emergencies. So, point, recognize the need for good, precise, closed-loop, effective communication, preventing and managing a crisis situation. Understand the basic principles of crisis management. Recognize the inherent importance of team mechanics in crisis management. Describe evidence-based strategies that improve performance and then hopefully outcomes. And understand the evolution of from problem to adverse outcome. Did everyone read the article? Okay, what did you all think of that article?
I actually did.
Yeah.
Yeah.
All of them.
The guy who kept yanking back on the.
Don't you realize at some point that you're falling?
No, I guess you're inside a concrete.
Yeah, I think so. I don't think you're. Okay, well, let's talk about that, the article at the end. But everyone got it and read it? That's good. It's a wild article. Okay, so requirements of high reliability organization. So about 30 years ago now, the ASA did a study where actually aviation started it. So aviation came up with this idea of high reliability, this idea of high stress, high risk environments, and decided that they were going to observe every catastrophe that happened in the aviation industry over the past some number of years. And they recognized certain cultural and systemic issues that led to these problems. Then the ASA tried to model themselves after aviation, and this term called high reliability organizations came about. First started in aviation, aircraft carriers, nuclear power plants, and then the military. And then the ASA and anesthesiologists kind of saw that there was lots of similarities between those organizations and how we behave and interact as anesthesiologists and in the operating room. And they determined that these requirements we're all needed for what are termed HROs or high reliability organizations, and that's sensitivity to operations, preserving constant awareness by leaders and staff of the state of the systems and processes that affect patient care. This awareness is key to noting risks and preventing them. Reluctance to simplify. Simple processes are good, but simplistic explanations for why things work or fail are risky. Did you all get the slides as well? Did anybody? You guys have you been looking at these beforehand or just having them available? I'm just wondering. I don't really care if you did or didn't.
They emailed it to us.
They emailed to you. Okay. Is this the last lecture of the whole thing? Okay. Have they been good, the lectures? Yeah. I did my residency here, and I can just say that when I started, I don't think they were very good. Maybe this one will be good. I don't know. Maybe it'll be terrible. But the point is, I just don't think we used to not have a very good curriculum, and I think they've done a lot to make that more streamlined. Anyway, preoccupation with failure, deference to expertise, and resilience. Would you say you agree or disagree with these requirements of HROs and that anesthesia meets that requirement? Agree? I agree. I think, I think in anesthesia oftentimes we do have we do simplify things. I think we do recognize that it is a complex process overall and that there are inherent risks to anesthesia, and we put a lot of things in place to try to prevent those from happening. Okay, so a culture of safety. I think you'll notice at this hospital and when all anesthesia and all hospitals that you're going to go to that anesthesia in particular has a culture of safety, and we try to recognize that and begin that from the time we start our mornings, which I think you can evidence now by your machine checkout, your preparation of drugs, your discussion of the case with your attending the night before, your plan for the case, attempting to prevent issues from the moment you see a patient and recognize their airway, whether it's difficult or not difficult, and if it is, to have airway plan in place. This is what is considered a culture of safety. We have a commitment from the top down, and I think that's also something that you recognize, that we have a team in place that begins the process from early. So one, we have a department leadership that recognizes the point of safety, and in prevention of issues, we've developed a pre-anesthesia clinic to help direct patients that are more complex into to begin this process of minimizing risk. We have all our resources are available. You're going to go to places that have much less resources. Everything here that you could ever need is available, and if you don't have it immediately on hand, you can ask for it and you would get it. We follow protocols. We have safety is valued. If you have a concern before a case or anything were to start, you're allowed to speak up. I don't think you would ever be discouraged from speaking up. I don't know, has anyone had any issues where they felt like they needed to talk to someone that didn't feel safe, they didn't feel like they could do their job appropriately because of lack of resources, or they were being pushed to do something they didn't feel comfortable to do? Good. I don't think you very often will. There's communication across all levels, and it's valued and encouraged. There's an openness about errors, and they're reported when they occur. Has anyone had any kind of an error that they need to report? Yeah? Carla? Good. And did you find the mechanism straightforward? Did anyone follow up with you? Not yet. It just happened yesterday?
This week, but we talked about it in our QI yesterday.
Oh, you guys have QI?
Well, after Volcom,
Oh, yeah.
gave a QI lecture.
Okay. And I think the format now is called an RL or something. Yeah, that's it. So we have a very, what would it be? A process in place called RL. I don't actually know what it stands for. I haven't filled it out yet, but it just changed. We just call it QI note. But you put it in place. It's sent to multiple people within our department who manage our QI team. And typically, if they feel like it warrants a review, they will contact you and talk to you about it. I guess I've had a couple cases where they've contacted me recently. But it's all very, what's the word, like, they're not trying to accuse anyone of anything. They just want to get to the bottom of it, and they want to find out how we can improve or prevent it from happening again. So I encourage you to be open and honest about any issues that come up through that process. So how does a crisis begin? Has anyone seen this graphic 1,000 times now as an intern? So it just goes to show that systemic issues can occur, and due to other conditions, one error leads to another, it leads to another error, and we try to prevent those. So latent errors occur and predisposing factors occur, psychological precursors happen. All of these errors lead to bigger adverse outcomes. What we do in terms of operating room emergencies or crises, putting evidence in practice. So utilization of written checklists has been shown to be, or proven to be beneficial in, during times of crises. You'll see this happen with yourself. It happens with me. The energy level goes way up in the room. You can become everything can become out of control. So we put a checklist in place, and that has been shown to help people during these times of crisis to navigate the issue. Obviously, what I would say the most prominent one of these is just ACLS. Checklist, algorithm. Have you done these things? And we try to do them as often as possible. Hold on just a second. Pull something up. Stanford, I'm just going to Google up. Wow. No internet. A buddy of mine at the University of Michigan sent me a bunch of checklists that I'm going to try to find really quick and send them on to you guys. I forgot about doing this earlier, so I'll do it in a minute. So we utilize established protocols and procedures, training and practice of simulated situations, and then the debrief. This has been shown to be, this process has been shown to improve outcomes. Are you guys going to get some simulation this year? Have you done that yet? No? Okay. I thought we were working on getting that going. Has anyone read this book? Yeah. So just Atul Gawande is this Harvard-trained general surgeon, maybe cancer surgeon as well. He's written several books. This one just talks about, and he studies aviation and how they go through a very just thorough checklist before they take off, and studies other areas where the checklists have been shown to decrease risks and improve outcomes. And I'd recommend the book. I haven't read the whole thing, but I've read some of it. Just very thorough evaluation of how checklists and protocols and algorithms are beneficial overall. So who could tell me, what do you think of critical incidents? And this was done a long time, in 1984, but a follow-up study was done in the late 90s and then again in the early 2000s to look at the most common. So this is done from the ASA closed claims database, which is people who filed a lawsuit against an anesthesiologist or anesthesia provider, whatever. They looked at which ones actually led to a closed claim or payout, and what were the most common causes of critical incidents related to anesthesiology. Who's it? Nerve damage? A critical incident. I guess we're not going to call that, like, we're talking one that led to, like, mortality. Equipment failure. What equipment?
It's the machine, I'm assuming, like,
Yeah.
circuit.
Circuit. Breathing circuit. Number one. Any others?
Wrong medication.
Wrong medication. Yep. What things can you do that can actually kill a patient?
There was an incident that happened at my intern hospital
Yeah.
where a CRNA accidentally gave rock
Mm-hmm.
instead of midazolam walking back the patient. Took off.
Holy crap.
And the issue was it's like a 5, 6, 7, 8 minute walk. It's like
And the patient just quit talking by the time they got there.
and they thought they were just sedated.
Oh my gosh. And
The patient was like saturated like 60s, 70s when they got to the OR and they had to resuscitate the patient.
wow.
So that was
That is bad. But these are the kinds of drugs that we're working with, drugs that can kill a patient on a daily basis. The important part of the checklist. Okay, so medication swap. Here we go. I forget the total number, but breathing circuits, disconnect, leak, misconnection was the number one cause of incidents. Medication-related syringe swap overdose, IV line disconnect, and then breathing tube misplacement was commonly in the esophagus, unintentional or premature extubation. Okay. Man, I've got quite a few slides to get through here in about 5 minutes. Dynamic decision making. So, in the moment of a crisis, you're required to make decisions on the fly. Even though you will use some protocols, you still have to make multiple decisions at the same time. So, prediction of future states. This is going to happen before you even go back. What is the likely response of a patient to anesthesia, to the surgery? I don't know why I put machine preparation in there, but for example, the type of surgery you're going to do will change how the patient reacts to anesthesia. Is the patient old with an EF of 30%? How are they going to act to induction of anesthesia? Or do you change your anesthesia or induction plan based on the patient's prior comorbidities? What and how do you set up your airway? You know, Dan and I and Vicki and I talked about this the other day in preparation for difficult airway. What equipment do you want to have in the room? Do you need to have it ready and prepared, even if you don't open things and use them? And this is part of just predicting and planning the future state. You know, you have a patient with severe aortic stenosis. How do you induce a patient like that versus a healthy patient? This is that kind of thinking. Going through if-then scenarios. So if I induce with propofol and the patient becomes hypotensive and they do have aortic stenosis, how are you going to treat that successfully? If this patient is coming in with a trauma and is hypovolemic, how do I induce anesthesia? Or if I can't intubate or if I can't do whatever, what do you do in the next scenario, the next case, which we'll do tonight or this afternoon? Resource management. Once a crisis occurs, how do you become the captain of the ship? What is your role? You become the person who allocates resources. You take control of the situation. Did you all do mock codes? Hopefully as an intern, right? Yeah. Okay. So on the floor, when you go into the ICU, you'll certainly manage more than one code, I'm sure. But in the hospital now, we've developed this thing where the intern year that I did was at St. Joe's. Anybody go to St. Joe's? Where anyone do medicine? Both surgery? Okay. Well, what they do over there is, and I think they do a much better job of code situations. I don't know if it's just because it's smaller and they have less residents and less people carry it back into the room, but here it just becomes a monster. But over there, they have the ICU medicine team is in charge of the code, and when they get there, they put on a red hat to know who's in charge. Just to help. Here, we just developed a system where you put on a yellow vest. The person wearing the yellow vest is in charge of the code. In the operating room, you will be in charge of the code, no matter what. The anesthesia team runs the code. And so you shouldn't have to put on anything, and the surgeons will look to you immediately once this happens. If there's an arrest and you say, or whatever situation there is, once it becomes a crisis situation, I think this is an interesting thing because I'm sure you've all seen that surgeons are in charge of the operating room at this point, right? Whatever they say basically happens. But once there's a crisis, and this has only happened to me maybe 5 times, when you take over, they will do whatever you say. And it is an incredible thing to watch, this role reversal of you are in charge, you run the show, what you say goes, and things don't continue until you say things can continue. So you allocate your resources. You will define someone to do chest compressions. You will define who will be doing the recording. You'll tell the pharmacist what to do. You'll dictate if you need more lines. You'll be telling someone to do lines. You'll tell someone to start infusions of whatever medications you want. But you will be in charge, and that's one of the most important things that can happen in a code situation is who takes control and who's making the decisions. That doesn't mean every decision you make or you have to know how to make every decision, but it means that people are going to look to you to make those decisions. So then you action implementation, reevaluation, key points. Here we go. Geez, Louise, is 6:58? How did that happen? I guess we got to go. Declare an emergency. This is part of the big thing, is declare an emergency. We'll cover a little bit of this afternoon. And next time, this is the last one, whatever, establish roles. God, how did this happen? Well, we'll finish up. We'll cover the rest in like 10 minutes this afternoon. The big point of this is really communication and how you establish roles, allocate resources, and manage the environment in a controlled, calm way. Because you will set the tone for a crisis. And the crisis can become out of control quickly. Even in an operating room where all the resources you could ever need are available, all the staff is available, and you have a patient who's probably intubated and on drugs that you could use in a code situation already, it will become out of control. And it's your responsibility to communicate effectively, declare an emergency early, to manage and control the situation and make decisions that are most appropriate for the patient. That's kind of the situation. In a nutshell, that's what OR crisis management is about. We'll cover a little more this afternoon. And man, sorry that I took too much time talking. Nice job. Nice to meet you all. I'll see you in several hours. Hope you have great days and you don't have to manage any crises. We meet back over here. Is that right?
Yeah.
What time have people been meeting to? Have you been staying till 5?
Haven't opened it or
I saw that as like 3:30 to 5.
Just
Feels
Yeah,
great.
I know.
Just use PowerPoint for justice.
Okay. Well, we'll try to cover at least 2 scenarios. Since it's not like a simulation, we can't really do roles, so we'll just kind of cover it. Good job. Sorry. Thanks. Yeah. I'll see you this afternoon. Dan, you seen our patient yet?
I've not seen a picture.
Okay.
Yeah.
All right, let's go see her. I think.